room. So we might actually get going. So welcome to the sixth and final episode in our lovely pilot program, which we're going to be talking about psychostimulants today. Colin, if you could go to the next slide. Where are my slides? Yep, go back one. Don't you love technology? Okay, just acknowledgement of country as we gather for this meeting physically. Well, some of us are physically dispersed, aren't we, and virtually constructed. Let us take a moment to reflect the meaning of place and doing so, recognise the various traditional lands on which we do our business today. We acknowledge the elders past, present and emerging of all the land we work and live on and their ancestral spirits with gratitude and respect. Thank you, Colin. Next slide. And we'd like to also thank AbbVie for their support in this program. Is AbbVie still here? No, they've gone. Okay, they will be coming in later at 12 o'clock just to maybe have a 5-minute discussion with you guys. So we're going to get moving into this. I'm going to hand over to Mandy, and I forgot your bio. Mandy just needs to move very quick because she's needed in the next room. So I'm going to hand over to her. Thank you, Mandy. Remember equine therapy.
Hello. Thank you. Just going to put my phone there. Okay. Good morning, and thank you to the CCC team for inviting me here today. I would like to acknowledge and pay my respects to the Aboriginal and Torres Strait Islander people who may be here today, and acknowledge the wonderful land on which I'm presenting and the contribution of our First Nations people. This is a very brief overview, very, very brief now, very speedy, of just what we're just going to be discussing today. If you do have any questions or comments, I really would like some comments, please jot these down and we'll just do that at the end, if that's okay. So let's go. All right. Okay. So my first slide actually presents some, I would say, alarming evidence that was first published in the Journal of Forensic Sciences and was actually conducted by NDARC in 2019. And it looked really at the development of cerebral vascular accidents or stroke in people. So essentially between 2009 and 2016, 279 stroke deaths were examined, and it was discovered a fifth of those deaths were people aged 15 to 44, commonly had been consuming methamphetamine. Furthermore, of those deaths, there were no known risk factors, so no hypertension or things like that, or any evidence of prescribed or non-prescribed ADHD medication, so commonly our stimulant medications. Okay, so just keep that thought with you as we go through this presentation. So psychostimulants encompass an extensive number, but all within the same class, that is stimulants. Now, this is a very busy slide. I have lots of busy slides. You will get a copy of this, so just bear with me. So if you have a look on here, I will start with caffeine and nicotine. So caffeine has stimulant effects, but it does not interact with the reward system. Nicotine does activate with the reward system, and we'll talk about that in a little bit more detail as we go through. There's actually been some positives found with having caffeine though. So one of those being that it can manage headaches. And if you've ever had a CT angiogram, they often, after they've given you that dye or that procedure, they encourage you to have extensive amounts of coffee. So because you've had dilated vessels and it actually constricts. So the nicotine one is very interesting because we now know that there's, and I'm sure that Renee will do this in her smoking talk, there's been evidence to show that smokers generally don't develop Parkinson's disease because of the dopamine effects. So, which is very interesting. And I've got more information on that if you would like some. Okay. Next slide, please. Oh, yeah. So this is really talking about amphetamines now. So this slide discusses the history. And as you can see, this was an accident waiting to happen. Really, we saw the advent of amphetamines really around World War II and thereafter, because it really gave people that bit of that oomph to go into war. Okay. Following all of this, it was then they started to use amphetamines in things like weight loss, and it was really one of those go-to medications until they realised it was just a bit too good for people. In Japan, around the same time in World War II, there was moves to create another form of amphetamine in the terms of methamphetamine, and this could be injected. Okay, next slide, please. Tell me if I'm going too fast or whatever. Okay. Okay, just check my clock. So I guess when we do talk about methamphetamines, I guess this is the drug that would be known as the scourge of society. Do you remember the government adverts back in the 1990s and more recently 2015 and the development of the ICE task force? Yeah. So I guess we're now learning more about the serious consequences of using particularly methamphetamine. For example, the cardiac effects. So we talk about QTc prolongation, leading to life-threatening arrhythmias such as Torsades de Pointes, which is a form of VT, but also that people presenting in the emergency departments really can be quite difficult to manage as well. I'm certainly always far more concerned about people who are intoxicated with amphetamines than I am with them in withdrawal. Next, please. Oh, we have to talk about ecstasy. This is the love drug. Okay, so a word on ecstasy being both a stimulant and having hallucinogenic properties. There tends to be a more gentle, I guess, intoxication with ecstasy in terms of euphoria, warmth, relaxation, often referred to as the love drug, because often people go around saying, I love you to anyone who will listen. Okay. Interestingly, there's evidence concludes with ecstasy is that psychosis is actually quite rare with ecstasy. So that was an interesting fact. Next, please. So with the family of psychostimulants, we go from low to high purity. So this is that versus. So in the 1990s, we saw much lower purity drugs that was around opposed to what we see today. Ingredients are easy to get hold of, so very synthetic made. And did you hear the talk from the doctor this morning about, the price of amphetamines has gone down? So easy to get hold of. Interestingly, though, people can sense if they've got low purity to high purity. So it depends, obviously, with what it's cut with. It's getting cheaper to use, and now we're seeing prices $50 to $80 for a point, which is 1/10 of a gram. Next, please. Okay, I'm just going to touch a little bit on cocaine, briefly saying that its prevalence in Sydney has increased. From the national survey in 2019, its use has increased as well, and I've got a slide for that. The drug typically is expensive and more exclusive, and historically, and if you look at that in the 2500 BC, they gave it to their workers so that they had increased stamina and productivity. I could probably do with some of that now. Okay, so next slide, please. Okay, I think this is a really important thing to talk with our clients about, because, and I do this with alcohol and drugs, it's not about the will of a person using drugs, it's about the effect that it's also having on their brain. And I think it's important to tell clients that. So I always talk to them about the normal reward pathway and then what the drugs do to those reward pathways afterwards. I really like this little slide because it's just telling you about, these zipping up and down electrical impulses, and then they've got a gap, which is your synapse. So you need a neurotransmitter to help carry the message through. If you put it like this, people tend to understand it. There is a pattern, and we had some fabulous talks yesterday about this. There's a pattern of repeat, repeat, repeat to survive. So this is where we see these repeated activities happening where we look at neuroadaptation of the brain, but this is what keeps people using. So unfortunately, psychostimulants, do they work at the synapse? There is a great infographic on something called bluebelly.org. I don't know if that's actually even still available, but it's, if you look it up, you can't access it via government computers because they always shut it down. But it's got an infographic and it shows exactly what methamphetamine does when it actually blocks some of those synapses. Okay. Neurotransmitters are not stored well in the body, so reuptake is important and essential. So eventually, if the methamphetamine blocks that reuptake, eventually the supply is going to run out. We often refer to this as the crash. But I think it's very important here that some research was done by Odyssey House a few years ago, probably around 2015, and they said that 60% of people using at that time, you wouldn't even know. Okay? So not everybody has a crash. Some people might just kind of be a bit cranky, something like that. Neurotransmitters are developed from the adrenal gland and they are derived from food. So the big message is get your tryptophans. So tryptophan is something that produces these neurotransmitters, and you get those from cheese and leafy vegetables. So we always concentrate on diet for people when they're in patients with us. Next, please. Oh, yep, this one. So high levels of these neurotransmitters, are they good for us? Is it good to always be on the go? No, it's not. Being in flight and fight mode is actually exhausting and can lead to lots of chronic disease. Next, please. Okay, this is the up and down. So you can see from this slide that moderate arousal is beneficial to cognition, whereas too much activation leads to cognitive impairment. This is probably not something new. I particularly like this slide because it tells you how we start in wakefulness, and then if we continue having that psychoactivation, what can happen. And then your body eventually, as a physiological response, will eventually say enough is enough. Next, please. Okay, a couple of stats here. So I'm sure people in the room may remember what happened to amphetamines, particularly around 2000 and the heroin drought and the advent of cheaper substances to replace. From the survey, peak use was in around about 2000, but it's steadily been declining. And as with all of the drugs and alcohol as well, people over the age of 40, if they were using, they're still doing it, but they're stabilising on it. Of course, you're going to have your peaks. There's been some peak ecstasy use from time to time, things like that. There's also some stats there on recent use of cocaine, which I thought was quite interesting as well. Okay. Next, please. So our short-term effects. So in low doses and moderate to high. Some anecdotal evidence on formication. So this is typically what was we know as electric bugs. So these are the people that you might see the little sores on the faces and things. There's been some information to say that really that can be attributed now to also a slight rise in temperature. So it's a bit like if you've got a mosquito, because you've got that very slight rise. So it may not always be associated with a psychosis. Okay, so just to be aware of that. My experience with people having amphetamines and the short-term effects are that they tend to be extremely disinhibited and they're just in your face. So they've got no personal space, boundaries, and they're loud. Has that been your experience? Next, please. Yeah. So these are some of the long-term effects, and you can see as we go through that there is those other more serious side effects or outcomes that we may well be seeing in the future. And I remember Odyssey House at the time in 2015 saying that recovery from amphetamine use can take up to about 18 months. And in the future, our nursing homes are going to be filled with people with cognitive impairment, just as they are now with Korsakoffs, with alcohol, that we're going to see these kind of groups. Of course, the risk of contracting STIs and all of the things that come with all of those long-term effects. Next one, please. Okay, I always like to use the DSM-5. If you've heard me before, I do talk about this, and pretty much the criterion is the same for amphetamines. So it's really about a use in a 12-month period, and you've just got the things there about the 11 criteria, withdrawal tolerance. I'm very keen to talk to people about guilt, as in, are they guilty if they haven't been able to cut down? How do they feel about that? Do they make promises to themselves not to use? So those are all very key features of a use disorder. Next, please. So we can have mild, moderate, or severe. Please note that caffeine and nicotine are actually separate use disorders. Were people aware of that? So, yeah, I thought that was quite an interesting one, that they are separate. Okay. Next, please. So this is about some detail to be included in assessments. It's always good to get a very clear history, but I think your timing of getting assessments has to be very critical, and I'll talk about that in a moment. But certainly things like bloodborne virus screening is really important because of that disinhibition, or I'm not even sure that's a word actually, and the psychological withdrawal. You may, at this point, when you're doing an assessment, just need to provide basic needs care for a person. So give them something to eat, let them have a sleep, and come back to them. Okay. Next, please. So signs of withdrawal. So these are a couple of probably of the most common ones. There may be none at all. And as I said, we've got information to say that we might not know if someone's even a user unless they tell us. And in fact, it might take a person up to about 5 years to actually admit that they've actually got an issue with amphetamines anyway. Okay. Next, please. So this is our management. This is the juicy stuff, okay? This is actually probably the worrying time for your client's safety and that of your staff. Although it's interesting because if you remember the adverts and they had the nurses in ED being punched and things like that, they shifted away from that fairly quickly and brought it back to the home. And in fact, it had, like the son shouting at his mother or something like that. And although there is still definitely verbal aggression and violence, more often or not, it's that, in your face kind of aggression that tends to be more problematic. Basic monitoring when people do come in intoxicated, if they are being brought in by police on an EA or something. If you can do an ECG, good luck. If you can do some kind of monitoring of that is really good though. QTC prolongation is a side effect of amphetamine use, but not for everybody. What do we do about it? We just monitor it. You manage any arrhythmias that come about from it, and you wait for the drug to get out of the system. Okay. It might be useful to do a urine drug screen if you can get that cooperation. But what we want to do is listen to the person and ask them, what have you used? Be aware, though, that if you do have QTC prolongation and it's greater than 500 milliseconds, so in females, 470, in males, 450, if you do get more than 500, do consult with a cardiologist. Okay. They're probably not going to do anything about it because it's really just waiting for that drug to leave. The biggest thing that we also need people to monitor for is serotonin crisis. So again, serotonin crisis, so we know that dopamine, serotonin, are all of those neurotransmitters that control behavior, mood, things like that. And if you get too much of it, it's going to be toxic to your body. Serotonin crisis can be extremely dangerous. I've never seen it, but I've kind of seen what I thought might have been, but it was actually, it was severe hypertension that the person had, and we did have to give them an antihypertensive. Okay. but you can actually end up needing full intubation if it's really, really bad. Probably one of the most important take-home messages is about how to use de-escalation techniques and not be in people's faces. So short, sharp, clear instructions to the person. Don't waffle on about things like rehab, stuff like that, because their cognition is all over the place. So in and outpatient treatment, so when we talk about withdrawal, and this is when our addiction specialists would say, oh, I don't care about them being in withdrawal. That's easy, right? In our model in Canberra, we're actually moving away from inpatient management of amphetamines because we have very structured programs for our alcohol use disorder patients. But what the stimulant users, you know, they just want to sleep, they just want to eat, you know, and this could go on for a couple of weeks. So our model doesn't really fit them terribly well. So we've gone more to an outpatient model, but that's kind of a bit tricky as well because what do we offer them? We'll talk about that in a moment. So as I said, one of the biggest things is giving them a really good diet. Okay, next please. Okay, so rehab and counselling are still the gold standard treatments, although there is a talk coming up about methamphetamine treatment, so it'd be interesting to see what else that's saying. There have been some trials of lisdexamfetamine, not conclusive as a replacement medication, and modafinil, which is normally used as a treatment for narcolepsy, is being used off-label in some centres. Now, according to the South Australian website, modafinil can be used as a treatment. Okay. Yeah. So we'll just talk about medications, and this is really about the withdrawal. So this is managing some of that irritability and some of the associated withdrawal symptoms. So you've got them all there. I just want to mention ondansetron. I really like ondansetron, but you have to remember ondansetron does have QTC prolonging properties, okay? As does a lot of drugs. And if there's anything I found in being a nurse practitioner is that that's the thing that comes up time and time again, okay? So a better alternative may be metoclopramide, for example, but be careful because metoclopramide in young people, you can have those epilepsy symptoms as well. And I've seen that quite a few times. Okay, so these are some of the resources. I would really urge you also not to forget the families, okay? The families, I think, it's a very difficult position because they often want them in hospital because they're too difficult to be at home, particularly if they're in that older age group, sort of early 20s and still living at home. That's a really difficult time. We know that most people using amphetamines now are in their 30s, around that time, but just so that you know that we really need to make sure that they've got support. So family drug support is a really good one for that. And next one. Okay, so these are some of the references. I do have some ADF brochures there, not many, but there's a lot of resources everywhere. Has everyone got the Breaking Ice or Cracking Ice or something app on their phone? That's it, Cracks in the Ice. Yeah, so that's actually quite good as well. Okay, and that's it.